Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. So let's talk about the respiratory system. So first, let's talk about assessments. So there are different breath sounds that you could potentially hear. So the first is called a friction rub. This is caused by rubbing of the pleural surfaces against one another, usually as the result of an inflammatory process. This is going to sound almost like a kind of rubbing, squeaky noise. Okay, then we have rales, also known as crackles. This is an adventitious breath sound associated with pathology, meaning there's some type of infection, pneumonia, something like that, something that is making the lungs crackle. These rales or crackles could be the result of air bubbles or secretions or movement of fibrotic tissue during breathing. So again, this is going to sound like a crackle. Almost sometimes people say that it sounds like when you rub your hair together. That's the noise you'll hear. Then we have bacillary rales. These are often accompanied by left ventricular congestive heart failure, so electrolysis, fibrosis, and pulmonary edema, and it's related to the opening of previously closed small airways and alveoli. Then we have rhonchi. This is a continuous, that's the key word, continuous, low pitch, sonorous breathing sound that are more prominent during expiration. That's another key thing, prominent during expiration, and could be the result of air passing through the airways narrowed by inflammation, a bronchospasm, or secretions. And again, heard during expiration. That is a key. Then we have stridor. So again, this is a continuous adventitious sound of inspiration. So this is key, inspiration, associated with an upper airway obstruction. So again, you're only hearing the sound when they breathe in. So wheezes, this is a continuous breath sound that are high-pitched and musical. So if you ever see something asking about a musical sound, that's going to be wheezes. And they're often associated with asthma, COPD, and foreign body aspiration. And we should always remember that with our nursing interventions, patients with any type of respiratory disorder should have the head of the bed elevated. All right, so let's talk about risk factors for respiratory disorders. So we have allergies and crowded living conditions, chest injury, exposure to chemicals and environmental pollutions, family history of infectious disease, frequent respiratory illnesses, geographical residence and travel to foreign countries, smoking or chewing tobacco, and viral illnesses. So the first chest injury we're going to talk about is called flail chest. So the signs and symptoms are a paradoxical respiration. So this means an inward movement of a segment of the thorax during inspiration with outward movement during expiration. So the way you can think about this is the chest is moving the opposite way you would expect. So typically when people breathe in, their chest expands. When they breathe out, it relaxes, it decreases in size, but this is having the opposite. So you're getting that inward movement that you would usually get when you exhale during an inhale. And then the opposite, when you exhale, you're getting the outward movement. That's a paradoxical respiration, and that's a sign of flail chest. Severe pain in the chest, dyspnea, cyanosis, tachycardia, tachypnea, hypotension, shallow respirations, and diminished breath sounds. And again, we want to remember that when we're looking through all of these different diagnoses, we want to pick out what are like the key big differences. So for flailed chest, you're going to see those paradoxical respirations. That most likely will be in the question if they're asking about this. So our nursing interventions, these are going to include maintaining the client in Fowler's position. That is usually the answer for anything respiratory related. We want them in Fowler's because when you sit them up to high Fowler's, you're actually pressing the diaphragm a little bit so they can't get as deep of breath. So really the best position to get them in is a Fowler's position. We're going to limit activity, administer oxygen and pain meds, monitor for increased respiratory distress, and encourage coughing and deep breathing. All right, so let's talk about a pneumothorax. So signs and symptoms include absent breath sounds on the affected side. So that is the key for a pneumothorax, something really important to remember, the things we want to pick out. So when you're listening to breath sounds, if you're not hearing sounds on one side, it's because they could have a pneumothorax. You'll also see the cyanosis, decreased chest expansion unilaterally. So because they have a pneumothorax, their chest isn't fully expanding on that side. So you'll also see this is another key point. Dyspnea, hypotension, sharp chest pain, subcutaneous emphysema as evidenced by crepitus on palpation. So if you feel their chest and you're feeling what sounds like cracking, it's air under the skin, and that is another key thing of a pneumothorax. If they have a sucking sound with an open chest wound, that's another, that right there is pretty obvious, right? If there's a hole in their chest. Tachycardia, tachypnea. The other really important thing is tracheal deviation to the unaffected side with a tension pneumothorax. So part of your head to toe assessment, you're looking at the trachea, you're making sure the trachea is midline. If it's not midline, it's pushed over to a side. It could be that they have a tension pneumothorax and it's going to be on the opposite side of the way the trachea is deviated. So again, the deviation is towards the unaffected side. So our nursing interventions are going to include applying a non-porous dressing over the open chest wound. We're going to administer oxygen as prescribed, place them in Fowler's position, prepare for chest tube placement, which will remain in place until the lung has expanded fully, monitor the chest tube drainage system, and monitor for subcutaneous emphysema. The next thing we're going to talk about is a pulmonary embolism. What you're going to see with these patients, this is a blood clot to the lung. This is a clot in the lung. So you're going to see apprehension and restlessness. They're going to start to have blood-tinged sputum, chest pain, cough, crackles and wheezing on auscultation, cyanosis, distended neck veins, dyspnea accompanied by anginal and pleuritic pain, exacerbated by inspiration. So when they breathe in, it starts to hurt more. Feelings of impending doom. This is a big one that you will see on questions. If they talk about that, patients are feeling there's an impending doom. Sometimes that can indicate a pulmonary emboli. Hypotension, petechiae over the chest and axilla. So that's another kind of specific thing to a pulmonary embolism. Shallow respirations, tachypnea, tachycardia. So our nursing interventions are going to include notifying the rapid response team and healthcare provider, reassess the client and elevate the head of the bed, prepare to administer oxygen, obtain vitals, check lung sounds, prepare to obtain an arterial blood gas, prepare for the administration of heparin therapy or other therapies, and document the event and interventions taken. All right, the next diagnoses we're going to talk about is tuberculosis. So this is an infectious respiratory process caused by tuberculosis bacilli. So the diagnostic tests that we are going to use include APD, which is a purified protein derivative. So this is given as a subcutaneous injection, typically in the forearm. So what we need to remember is that a negative test will be between 0 and 4 millimeters after 48 hours with redness, but without induration. Induration is a bump. A positive induration is going to be anything greater than 15 millimeters in a healthy individual or 10 millimeters after 48 hours in immunocompromised individuals or 5 millimeters in high-risk individuals such as those with HIV. A positive test with no symptoms, the patient gets a chest x-ray, and a positive test with symptoms, the patient gets a sputum culture. The next type of test is a sputum plus for myobacterial tuberculosis. So again, this is the sputum culture. So This will happen within 2 to 3 weeks of onset of symptoms, and it will be negative if the disease is in the latent phase. So our treatment is going to be, the drug of choice in most cases is going to be isoniazid or rifampin, and they typically do these together. So treatment will depend on which type the disease is in. So if it's in the latent phase and it's asymptomatic, and there'll be no tuberculosis transmission, normal chest x-ray, no sputum needed to be collected. That's fine. Patient's fine. However, if they're in the active phase with cough, fever, chills, weight loss, anorexia, fatigue, TB can be transmitted, have abnormal x-rays and a positive sputum culture. So symptoms, we're going to see fatigue, lethargy, anorexia, weight loss, chills, fever, chest pain. And our nursing interventions are going to be airborne precautions for TB always, because it spreads through the air. So we need the filter on an N95 mask. The room should have 6 air exchanges per hour. And patient is to wear a mask if leaving the room. All right, so asthma. This is airway inflammation that can be caused by hyperresponsiveness to allergens, exercise, or irritants. Signs and symptoms are wheezing, shortness of breath, coughing, or chest tightness. Our nursing interventions, our priority is always keep the airway patent, right? Because our ABCs, airway, breathing, circulation, and then to administer systemic steroids. So what does this mean? This means if you get a question about somebody having an asthma attack, well, systemic steroids, although they work long-term. This is a long-term treatment. So what that means is if they're having an asthma attack, they need a quick treatment. So this is when you would use something like albuterol. Okay, so let's talk about COPD. COPD is an airflow limitation resulting from a small airway disease or parenchymal destruction. So there are 2 types. You have chronic bronchitis and you have emphysema. So we can remember this as chronic bronchitis. These patients tend to look more like blue, where emphysema, they tend to be called red puffers because they're just kind of more red and they have what's called a barrel chest, so they're more round in their shoulder area. But all right, let's go through it. So chronic bronchitis, these people that have a smoking history or cor pulmonale, they have decreased expiratory flow rates, crackles, wheezes, and hypoxemia. For our emphysema patients, these are going to have those barrel chest. So that's like a big one that indicates emphysema. Again, the dyspnea, the cyanosis, they're going to have some clubbing and accessory muscles of ventilation. So our nursing interventions include a normal oxygen SpO2 is going to be 88 to 92, which would be low for a normal person, but that's typically where people with COPD live. So that's okay as long as they're not showing symptoms. We don't want to raise the oxygen level higher than 88 to 92 because a lower SpO2 is what stimulates COPD patients to breathe. So if we turn up the oxygen, their body is not going to make them breathe. So we want to keep them between this 88 and 92. Pneumonia. So pneumonia is an acute inflammation of the lungs due to bacteria, viral, fungal infection, leading to stiffening of the lungs. Diagnoses, we would do a sputum culture and sensitivity with confirmation of the organism, and this is how we can figure out which antibiotic to give because we're checking the sensitivity. And aspiration pneumonia results from the inhalation of foreign matter. Signs and symptoms are fever, pleuritic pain, so pain that is sharp and increases during inspiration, tachypnea, wheezing, accessory muscle use with breathing. We can see a changing level of consciousness and sputum production. Our nursing interventions, our priority is going to be droplet precautions. So we always want to remember with pneumonia, we're using droplet precautions. We want to supplement with oxygen, monitor their level of consciousness. We can have them do some deep breathing and coughing, semi-Fowlers to assist with breathing, chest physiotherapy to mobilize secretions, fluid intake to thin secretions, and antibiotics. Then we're going to talk about a pleural effusion. So this is a collection of fluid in the pleural space, preventing lungs from fully expanding. These patients are going to have pleuric pain, shortness of breath, dry cough, tachycardia, fever, and decreased breath sounds over the area. Our nursing interventions include the priority is to prep the patient for a thorough census. We're going to keep the patient in Fowlers, and we're going to monitor for breath sounds. The next diagnosis we're going to talk about is empyema. So this is a collection of pus within the pleural cavity. Our interventions are going to be to treat the infection. So we want to figure out what it is, and we want to give some antibiotics that will treat that type of infection. We want to use high Fowlers, coughing and deep breathing, and a thoracentesis or chest tube for drainage. Let's talk about some respiratory interventions. So first we have supplemental oxygen delivery devices. So we want to remember these different face masks and cannulas that we can use to deliver oxygen. So the first one is a nasal cannula. This is going to deliver at 1 to 6 liters per minute with a FiO2 of 24 to 44%. And this is for patients on long-term oxygen use or with airflow limitations. Then we have a face mask. This is going to be delivered at 5 to 8 liters per minute with an FiO2 of 40 to 60%. And we want to monitor for risk of aspiration. For short-term oxygen therapy or for emergencies is when we would use a face mask. Then we have a Venturi mask. So this is 4 to 10 liters per minute with an FiO2 of 24 to 55%. And this is for patients in acute respiratory failure. Venturi mask. Then we have a partial rebreather mask. This is going to be delivered at 6 to 15 liters per minute with an FiO2 of 70 to 90%. We will adjust the flow rate to keep the reserve bag 2/3 full during inspiration. And then we have a non-rebreather where the rate of flow needs to keep the bag full. The FiO2 is 60 to 100%, and this is for patients with deteriorating respiratory status. So then we also want to talk about ventilator alarms. So things to remember with this is a high pressure alarm can be caused by increased secretions, tube kinks, patient biting on the tube or coughing, whereas a low pressure alarm can be caused by tube disconnection or the patient stopped breathing. Chest tubes. And with a chest tube, there are 2 different suction types. So we have a wet suction and a dry suction. A wet suction is regulated by the height of water. So we can remember wet, water. In the suction controlled chamber, the suction controlled chamber is filled with water, and the amount of suction depends on the height of the water. We want to see bubbling. Bubbling is good. A dry suction, the suction monitor bellow controls the amount of suction, and the amount of suction is controlled by moving the dial on the suction control area. Now, within the suction machine, we have different areas. So we have a drainage chamber. So this is going to monitors drainage, color, and amount. The normal is less than 100 cc's an hour, and it's located right below the tube that comes from the patient. Then we have a water seal chamber. So this again is going to be on our wet section. Water fluctuates with inspiration and expiration, so we want to see it moving up and down as they breathe. If there's no fluctuation, and that means that the lung has re-expanded or there is a kink. Then we have the air leak monitor. So if this has excessive bubbling, it indicates an air leak. And if patient has a pneumothorax, air in the pleural cavity, intermittent bubbling is okay. So what are our nursing interventions? It's going to depend what happens. So if we have dislodgement, we want to cover the area with a sterile dressing, tape 3 sides so that air can escape but not enter.
If there's a tubing issue, we want to make sure that the tubing is below the patient's chest, keeping it free from clots, kinks, and stagnant fluid. And during removal, we want to position the patient in semi-Fowlers, perform a Valsalva maneuver, and have them hold their breath. So some medications to remember related to the respiratory system include atropine, so used for severe asthma to help with spasms and involuntary muscles and inhibit secretions. Bronchodilators like epinephrine, alupent, Benetton, Proventil relax smooth muscles and open the airway. And corticosteroids like prednisone and cortisol are used to decrease edema and inflammation in COPD.
If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com.